Hi, it's Mark Rieger again. This is the Pediatric Orthopedic Podcast series in which we talk about topics that our patients want to hear about. One of the hot topics that our patients been asking about lately has to do with scoliosis and the rapid recovery pathway system that we're using. What's fascinating about this pathway when people are so curious is they remember the old days when people used to be in the hospital for a long period of time, used to be nauseous, taking a lot of narcotics, not walking, and being held in the ICU for several days and not recovering very quickly. With the rapid pathway system, people are now noticing that the surgery is on one day, and within 36 hours postoperatively, they're going home and they're doing much better. And it's a totally different experience than what was happening in the past. So the question is, how can we make such a change? And so there's a philosophical difference that's been made about how to treat pain. We don't treat pain anymore. We prevent pain. And what does that mean? Well, the body has a physiologic response to pain, meaning that if you get hurt, it automatically will release what's known as catecholamines. And that's a substance that will make you sweat, your blood pressure goes up, you vasoconstrict, meaning the blood vessels get tight to prevent blood loss, and it increases the intensity of pain to avoid that type of pain response, and it sort of stabilizes the body. It's essentially the body's way of triaging itself and trying to minimize the risk of the injury it just had. Well, when you have elective surgery, you don't need that triage. You don't need to have your pressure go up and pain response to avoid things. You can actually avoid that because the changes in the body are controlled changes, even though there's been injury to the body, but they're controlled injury to the body called surgery. And so what we do is before the body gets a chance to release these catecholamines that cause these issues, we give patients medication. So for example, before the patient is put to sleep, we'll give them methadone. And what the methadone does is not a narcotic, but it's a very good painkiller. And so before we even cut the skin, when the patient's asleep, the patient will not really have the same pain response. Now, this is an interesting fact that people don't understand. When you're under anesthesia, and an incision is made in the skin, you still feel a pain response. And there are changes. Blood pressure goes up, and you go ahead and we'll see that there is a vasoconstriction of the skin. So you do have a physiologic response, and you're getting this catecholamine release. However, when you give something like methadone beforehand and other medications to help minimize inflammation in this response, like Decadron, which is a low dose steroid, you don't get this catecholamine release, and therefore there's no pain amplification. So what happens? So we perform the surgery, and then what we'll do is before the patient wakes up, we actually will give the patient two things which helps them postoperatively quite a bit. The first thing is it's called Exparil, and I'll show you this in a minute, but they'll give pain medication, which is like a local anesthetic that the dentist that gives in the mouth before they do some type of procedure. And then there's also Tylenol given IV. And I'll give you a little chart on that in a second, go through that. And so it's blocking the pain response before you wake up now. And once you get the pain response blocked, then you're going to wake up. And there's other medications in which you can go ahead and try to minimize the discomfort. Let me just share my screen with you a second and show you what we're talking about. And let's go here. So here we have the modality management. So first, before the patient wakes up, we'll give the patient Exparil. It's a local anesthetic. Some people will know it as Marcaine. It lasts for 72 hours. It's given two ways. One is a block, and a block is a way of saying you inject a nerve, so a wide area of soft tissue is anesthetized. And we also give it locally, so topically, just underneath the skin. So the skin is numb for up to 72 hours. The second thing that we'll do is we'll start with Tylenol IV. And the Tylenol IV is high dose, and it's very effective in controlling pain management because you don't have a lot of pain because most of the pain response has been blocked. And then what we'll do is sometimes the kids will have spasm because we stretch out the muscles. And when you do that, the issue is the muscles go into spasm, and we will go ahead and give Valium. And that's just what we call PRN. PRN is a way of saying that only if you need it. And most kids don't, but if they do that, it prevents the spasm, prevents pain. The children will get opioids such as Dilaudid IV to help with some severe pain, what we call breakthrough pain, but it's minimized. And the nice thing about using the opioids on a lower dose for a short period of time, it minimizes the nausea, it minimizes the groggy feeling, the constipation that you get from that. And the more important thing, in my opinion, is that it lowers the risk of opioid dependence and likelihood of needing opioid later on in life for pain management. One other medication that we use is called gabapentin. And with gabapentin, this is a nerve stabilizing medication. Again, it dampens the pain response by stabilizing the nerves. The last thing, which is not listed here, is not really for pain management per se, is we give a medication called Restylor. And that's actually a fascinating medication. It's Narcan, which reverses the effects of opioids, but only the effects of the opioids on the gut. So you don't get that constipation associated with the use of opioids and the discomfort of feeling bloated. So with these modalities, it's very easy to minimize pain, and we get the patients walking the very next day, and they start eating the very next day after surgery in the morning. So their gut starts waking up. They start feeling better because they're walking. They don't have the respiratory issues because they're not laying in bed anymore. They don't have the nausea, the vomiting that the kids used to have. And so how does this really affect the patients? As we discussed, the patients have decreased pain, significantly decreased pain, where upon discharge from the hospital, they usually maybe take 1 to 2 doses of the Dilaudid a day for a day or two, and then they're off, and they're managed really with Advil, which is ibuprofen, and Tylenol every 6 hours. And it's very important to prevent pain, not treat pain. What I mean by that is when the kids are discharged and when they're in the hospital, they give them pain medicine before they have a pain response. Think about it. In the old days, when we used to treat pain, you used to wait for the pain, give a pain medicine, which now you'd get your catecholamine release. That would increase the pain, and it takes 30 minutes to ingest the medication for it to work. So you have to ingest it, wait 30 minutes to kill the pain. By now, the pain's even higher. By giving the pain medicine before you're going to have that pain, as the pain starts occurring, it's suppressed, so you don't get the catecholamine release with the amplified pain, and you don't have to worry about it needing a significant amount of pain medicine because you're not getting that amplification. And again, this pain management minimizes the risk of opioid exposure, which is a big deal in preventing future use of opioids and future risk of addiction. The hospital stay now, believe it or not, is about 36 hours after the procedure. So one day you have the surgery, and then after you wake up the next day, you're in the hospital for just a day and a half before going home. And you discharge with Tylenol, Advil, a little gabapentin you take at night to help with sleeping and pain management during night. And you do have an opioid just in case you have a little additional pain, and Valium in case you have a little spasm. You're off pain medicines 7 to 10 days postoperatively. But what does this pain management do? Well, it increases quality of life. You have much better patient satisfaction because they're walking, they're able to go to the bathroom for themselves, they're able to go outside, they're able to interact with their friends, and they get to be in their home environment, not a hospital environment. It dramatically decreased the cost to the family because they're there for such a short period of time and allows them to return to school earlier. It used to be about 6 weeks or longer before a kid can return to school. Now it's really basically about 2 to 4 weeks, depending on the demands in the school, for the kids to go back. So we'll stop sharing the screen now. And so that's the rapid pathway recovery system. So now when patients come in for surgery, that's what we try to do with regards to getting the kids back to activities a lot faster. If there's any questions about scoliosis, about the rapid pathway recovery system, we're always available. And please contact us and let us know what topics you'd like to hear, because we're here to educate. And we love when our patients are educated because it makes the experience for everybody so much better. Look forward to seeing you in the next podcast. Have a great day.